Good evening, everyone. Thank you for waiting. We might get started as we've got a lot to cover tonight, and also a lot has changed since our last CESPN COVID update, when things were perhaps looking a little bit more optimistic than what they are this week with what's been going on in Victoria and now what's been happening more locally around Sydney. So once again, we've got a number of very interesting presenters tonight. We're going to have each of our speakers to present for 10 to 15 minutes, and then we'll have a panel discussion at the end. Let me introduce myself. I'm Michael Wright. I'm a GP in Woollahra in East Sydney, and I'm the chair of the board of Central Eastern Sydney Primary Health Network, and I'm going to be your facilitator tonight. I'd like to start by acknowledging the traditional custodians and sovereign people of Australia on the land on which we meet, in the Central and Eastern Sydney region, but also people who are joining us from other areas around the state. We recognise the continuing connection of our Aboriginal people to land, water and community, and pay respects to elders past, present and emerging. And I'd also like to extend a welcome to any Aboriginal people joining us here today. I'd also like to take a moment just to reflect on some sad news that happened yesterday. As many of you will be aware, Dr. Harry Nespolon, who was the president of the RACGP, passed away after a battle with pancreatic cancer. Harry's been a great leader for general practice and for primary care, and was just coming to the end of his term as president, and his loss will be greatly felt by us all. So I just sort of wanted to pause for a moment just to acknowledge that. Tonight we've got 4 speakers who I'll introduce as we go through, and we've also been joined by primary healthcare practitioners from outside Central and Eastern Sydney. So welcome, thanks for coming. For those of you from Central and Eastern Sydney, you will have been emailed an evaluation form, and as always, it'd be really appreciated if you could give us some feedback on what works and what didn't work in tonight's session. After each of our speakers do their presentation, there'll be time for a couple of questions. You'll see there's a chat box within this format, so you'll be able to add questions if you like as we're going through. And then the final 30 minutes will be a panel session where all the speakers will be able to reflect on what's going well and what's potentially not working as well with regards to COVID. We've also got a series of poll questions which Bertha will start running. The first of those we might just throw up now, which is basically just asking you what your role is, sort of whether you're a GP, whether you're a practice nurse, are you a physio, a psychologist, another allied health provider, and hopefully that will come up any minute if the system is working. And I'm not sure that it has, but we'll wait 1 minute. Just to let you know, we have tested the audio and video prior to starting, and it did seem to be working well, although one of our speakers is having trouble logging in. If you are having trouble with your audio and video, please just log off or turn your video off, first of all, and that'll reduce the band usage, and then hopefully things will be able to settle, and then you can try reloading the web page. Unfortunately, we can't deal with individual problems at the moment. So I can't see that poll coming up, so we might move on for those and forget about those for the moment. Bertha, if you get that up and running, please do that a little bit later. We're very fortunate tonight to have our first speaker. Dr. Fiona Martin is the member for Reid. She's a member of the House of Representatives. She's a member of the Standing Committee for Health, Aged Care and Sport. And prior to joining Parliament in 2019, she was a psychologist in private practice. Fiona is going to speak about her experiences with COVID from a government perspective, but hopefully potentially speak about some of her experiences as a health professional and her perspectives. I'll hand over to Fiona Martin.
Oh, hi, thank you very much. I hope you can hear me here. I'm sitting in my electorate office in Burwood in Sydney, and I'd also like to acknowledge the traditional owners of the land I'm on right now, which is the Wongal people of the Eora Nation, and I acknowledge elders past, present and emerging. It's very exciting to be amongst health professionals. Most of my time these days is with parliamentarians, and and whilst they are quite diverse in their backgrounds and skill sets, I feel most at home with health professionals, so I'm amongst good company this evening, I think. It is true, I'm on the health committee. Before becoming the member for Wright, I was practicing as a psychologist for close to nearly 20 years, and my interests were mostly child and adolescent psychology. I'm an endorsed educational and developmental psychologist, so I certainly did my fair share of assessments for children with autism and various other neurodevelopmental disorders. So being a member of Parliament now is very different to, well, similar and different in many ways. I guess it's great to be a member of Parliament with a background in psychology, because I understand how to relate to people and build rapport with people, and to be able to talk to different types of people. And you do that as a member of Parliament. You come across a range of different people in your area who have varying needs and issues that they need to have addressed. So they're great skills to have behind you, I think, as a parliamentarian. In my first 12 months, because I've just had, in fact, 2 days ago, it was 12 months since I gave my first speech in Parliament. And in my first 12 months, what I've experienced is drought, bushfires, and of course, coronavirus. So it's been an interesting time to be a member of Parliament. I certainly don't think this has been normal, and I look forward to experiencing normal at some point. Dealing with a pandemic has certainly not been a normal experience for a parliamentarian. So since being elected the federal member for Wright, I have been involved in the NDIS committee as well, the National Disability Insurance Committee, and the Family Law Committee. And I'm also a supplementary member of the Social Policy and Legal Affairs Committee, which is going to be dealing with an inquiry into domestic violence, which will be, I think, very important. I'm also the co-chair of various parliamentary friendship groups, including Hearing Health and Deafness, which is a relevance to GPs, and also member of a variety of parliamentary friendship groups that relate to health and particularly mental health, because of course that's a very specific policy interest of mine. So I've been working very closely with Greg Hunt since I've been elected, and in particular his mental health advisor, who works extremely hard behind the scenes. So I thought I'd spend this evening talking a little bit about coronavirus from the government's perspective, and then I would, because I'm not able to sit at the end to answer questions, that I'd open it up during this period now to a few questions that you might have in relation to issues that relate specifically to GPs and to allied health professionals as well. And I think I can anticipate what they might be, but we'll get there. Look, obviously, you know, the numbers and our response to coronavirus has been one that I think that nationally we should be proud of. Since the initial outbreak, Australia has worked tirelessly to have testing up as high as practically possible in terms of getting out and rolling out the testing clinics and making sure that we have the capability to do so. And in fact, Australia is one of the highest testing, has the highest testing rate, one of the highest testing rates, I should say, around the world. And that's something that we should be proud of. Our tracing capacity is working well, and I think that we should also be proud of that. And of course, over time, we've increased our supply of ventilators and working very hard to stockpile the necessary protective equipment necessary to respond to coronavirus across the nation. I won't go through the numbers because, of course, you can all look them up on your apps that you probably have downloaded for the nation and also for New South Wales. But of course, we're all very happy that we're in New South Wales and not Victoria right now, who are dealing with a terrible situation there. I think our government's response from the beginning has if I just quickly go through a few things, the National Cabinet that was set up at the beginning was something that was really important, I think, to ensuring that we worked collaboratively as a nation and addressed issues across the nation in a way that allowed for collaboration, but also a unified response. One of the most important parts, I think, of the response by the federal government was closing the borders. And when that eventually happened, I think we were feeling a lot more relaxed in terms of, you know, knowing that the virus was coming in from people that were bringing it in from overseas. And certainly that was you know, an important part of the response. Mandatory quarantining is also another important component in our response, as has been the campaign around the health messaging for good hygiene practices, you know, how to wash your hands. My colleague, Dr. Katie Allen from the federal seat of Higgins in Victoria, has done numerous videos on how to wash your hands correctly, and we've worked really hard at spending significant amounts of money on ensuring that people across our community have the health messaging around good hygiene practices, but also social distancing and what have you. Collectively, the Australian government has spent over $8 billion on the COVID-19 health response. $8 billion just on COVID-19, a significant amount of money, and that doesn't include the loss of income and obviously GDP associated with the impact that it's had on our economy. And the Prime Minister has said from the beginning that this has been a twin crisis. It's the health crisis, but obviously also the economic crisis. And that economic crisis impacts our well-being too, because that's people's livelihoods. And, you know, I don't need to tell you that, you know, small business is the backbone of the Australian economy, and so many people that work in healthcare are in small business too. I know because I used to be one of those. I used to run and operate, you know, relatively small business as psychology clinics, and I understand the impact from hearing and speaking with colleagues that coronavirus has had on the running of small private clinics across the country. But in that $8 billion that the Australian government has spent on coronavirus to date, that's been spent on a range of things. $1.1 billion was to ensure patients and critical health workers have access to face masks, surgical gowns and goggles, antibiotics and antivirals. An estimated $500 million to pay 50% of the costs incurred by the states in diagnosing and treating patients with COVID or suspected of having COVID. 206.7 million for up to 100 dedicated respiratory clinics, which I'm sure your listeners, viewers are aware of. 170 million for a Medicare-funded pathology test for COVID. 100 million to enable aged care providers to hire extra staff for residential and also for home care. 100 million for telehealth services initially. 58 million for remote community preparedness and retrieval. So that was to ensure that our rural and regional communities are prepared. 30 million for a communications campaign delivering the health advice, and also not just delivering the health advice in English, but being able to translate that into 20 odd languages. And of course, my seat of Reid is one of the most multicultural seats in the country. So we have people in Reid whose first language is not English, and so it was so important to translate the health messaging into different languages, and I certainly pushed for that. 30 million for the COVID research, which include grants delivered through the Medical Research Future Fund, and then an additional 44.6 million has been spent in aged care workforce support program. And then just recently on the 29th of March, as part of the 1.1 community health package the government announced, 669 million was to expand the Medicare subsidised telehealth services, and it goes on and on and on. We've spent significant amounts of money, as you can see from just me being able to give you some figures there, that we've certainly had to outlay exorbitant amounts of money to respond to the crisis across the nation. Now, one of the two, at least two of the big issues I think that health practitioners are currently having to deal with, one of which is telehealth, and I understand, telehealth. I very rarely used telehealth when I was in private practice, mainly because I felt professionally that it was better for my clients, patients, that they come in to the clinic, and I felt that, professionally, that it was clinically better for them to build a rapport, at least initially, to build a rapport face-to-face with me as a health professional, and then for me to conduct testing and screening for psychological conditions when the patient was present. Now, obviously, when a pandemic is ripping through your country, it's very difficult to treat patients as normal, and so telehealth, I think, has been an important part of the response, but it's certainly and has been a bridge to treating and allowing patients to access critical health services, but it certainly has its limitations, and I understand that health practitioners around the country are wanting to give us, as elected members of Parliament, feedback around how that is affecting you in terms of delivering health services across the nation, but also in terms of how it impacts your practices because of the restrictions around bulk billing and what have you. So I'm interested to hear what people have to say about telehealth when I finish my part. And the other issue I think that's come up for health professionals has been PPE and access to PPE, and in particular face mask in healthcare clinics, and how to manage, I think, to some extent, the fear that patients have around attending health clinics and having the necessary COVID-safe plans in place and making that work in the healthcare settings. Since COVID started, the government has ramped up national production domestically for face masks. I think it's 30-fold increase in production at this stage now, and it will continue to increase. So we're certainly working on domestic supply chains and have done since COVID. But I think face masks and availability and access to face masks has been an issue for healthcare providers. I might at this stage, Michael, if it's okay, turn it to you and to see if there's anyone that's got any questions or would like to raise issues that relate to GPs in private practice, and to hear your thoughts about telehealth, because I've got my notepad here and I'm eager to hear what you have to say as well. But I can't hear you.
As I go off mute. Sorry. Thank you so much, Fiona. I think you've mentioned a couple of the main questions that people have come up with, which is this idea that although most GPs are broadly, supportive of access to telehealth, it's allowed us to keep providing care to people during the peak of the pandemic. Those limitations around bulk billing are affecting the viability of our practices, in that many of our practices are staying open and we're seeing people, but we've basically had to adjust our business model at the same time as we've been trying to cope with this pandemic. And many of us were unfamiliar with the video technology, well, because we'd never used it, obviously, but so we've used telephone for most of it. And as you've kind of already reflected, you get less information over the telephone and even with video than you do in face-to-face. So it takes more time, takes a lot more mental energy as well to be trying to work out what's going on when you've only got half the information. And I think, and also from a practice point of view, people are, we've reduced a lot of practices have reduced staff in some areas, but the reception staff are very busy sort of fielding calls, setting up people for telehealth calls. And, you know, the problems of trying to call people back when, you know, you call them, they don't answer because they don't recognize the number, and they call you back, by which time you see another patient. And I think particularly from GPs, the usefulness or utility of telehealth isn't as great because you've only got 15 minutes to do something. Whereas I think if you had an hour appointment, if your bandwidth problems are lasting for, you know, 5 or 10 minutes, you can still have a useful time. So I think it's just, it's very, we're very appreciative that we've had it. And I think GPs have been wanting access to Medicare funded telehealth for a long time. But as you say, it still has its it still has its limitations.
Yeah, and I can appreciate that, having owned a private practice, what that means. And it's critical that people are still being screened or seen and seeing doctors and seeking help during this time. But I do think that we're probably, people are going to be missing out on important appointments or screening because of the limitations at the moment. And I think there's also that fear factor of going in to see your GP whilst the pandemic is still in play, until we have, you know, I mean, obviously our approach, you know, we are aggressively trying to suppress the virus by implementing the various restrictions that we've had in place, and trying to get compliance with people, you know, social distancing and what have you. But there are just some illnesses and conditions that are just really difficult to work with over the phone or via technology, you know, and so it's critical that people still come in to see their GP or their health professional.
And I think the other important bit is just about the PPE. The PHNs have distributed masks, but GPs have really struggled getting access to anything other than masks. When we have tried to source gowns, if we can get them, the prices of them have greatly increased, you know, sort of tenfold what they were prior to the pandemic. And then you tie that with the reduced income from the bulk bill telehealth, and that's sort of just having a major impact. Now, we've got the GP respiratory clinics for us to refer patients to, but I think as GPs, we're still seeing people who potentially have slipped through screening, who come into our practice. So we're still using PPE, even if we're practices that aren't doing any COVID screening, we're still potentially being exposed to COVID patients. And just, I think there's some growing fear amongst GPs about, you know, can we keep ourselves safe as well as our patients safe?
Yeah, well, that's understandable. I feel the same way sometimes when I'm having to meet with constituents in many ways, that it's similar. We've had to develop a COVID safe plan so that constituents can still raise issues in a way that's safe. So similar but different. And obviously, you know, yeah. So one of the biggest issues is access. So masks are available, is that what you're saying?
So PHNs have been distributing the masks to all practices as well as pharmacies and also to aged care facilities, but we've had no access to gowns.
Right.
So that would be definitely something that would be of benefit. You know, just to, you know, as I said, we've sort of got this growing fear about this, the pandemic just rapidly overwhelming us, and that we've seen people in other countries, GPs dying from this, and people seem to be in a lot better PPE than what we have in most of our practices. So it's just, you know, I think it's a real fear that many of us have. So if you can do anything about that, that would be
yeah,
you know,
I will
really
look into that for you, absolutely. And obviously anyone who is a practicing health professional who has additional risk factors would need to take extra precaution as well.
Yeah,
and
exactly.
I would think that's, I mean, there's a level of personal responsibility there too, isn't there, in terms of keeping yourself safe if you're at increased risk. And the other risk factor is, of course, burnout, because it is a very, you know, difficult time. If you're on the front line, the impact of seeing patients who are very anxious and have other health issues, you know, that has an impact on how you you know, transfers So that's something to be mindful of as well. Taking good care of yourselves as health professionals is really important, more so I think now than ever.
No, look, and thank you so much. I mean, I totally agree, and I think burnout of we're worried about mental health for our patients, but also burnout of ourselves. So, look, we might hold it there because we've got a number of other speakers, but thank you so much for your interest and just taking an interest in us as primary care, because I think it's, you know, it's of great value to us to hear your interest and to know that we can contact you and that you're a willing ear in this space, because
absolutely. Yeah, I mean, absolutely. Anytime that anyone has an issue to raise, I'm very much, look, I work behind the scenes all the time. So I like directly working with our ministers and our advisors, and I'm very much amongst, you know, colleagues here, and I feel you're my people. So so feel free to reach out and contact me to raise issues, and I'll be advocating for you most definitely. Very important that you feel represented, and I encourage you to reach out anytime. Very happy to be your voice.
Thank you.
But lovely to be here this evening, and thank you very much for inviting me to participate.
Thanks so much, Fiona. And if we get more questions in the panel discussion, we'll jot them down and get them to you as well.
Wonderful.
Thank you so
wonderful. Much. Thanks, Michael. See you.
Thank you. Bye.
Bye.
Thanks very much. Our second speaker is Professor Mary Louise Mcclause. Mary Louise has been having some issues with technology, so I think we're going to have her by phone rather than video. Professor Mcclause is the Professor of Epidemiology and Healthcare Associated Infection and Infectious Disease Control at University of New South Wales, and a member of the World Health Organization Health and Emergencies Program Experts Advisory Panel for Infection Prevention and Control Preparedness, Readiness and Response to COVID. So she's a very well-regarded expert in this area, and I'm looking forward to hearing her insights into what the future challenges for GPs and the health system will be. Mary Louise, can you hear me?
I can. Can you hear me?
Right. Yes, loud and clear.
Excellent. Great. Okay. No one needs to see me. Good evening, and thank you for including me in your seminar tonight. So I'm just going to give you a bit of an idea of what we do at WHO, where we're at in our region, and then a tiny little crystal ball. But there's a good saying that predictions are always a surprise. So the next slide, please. At WHO, there are 9 themes for global research and development around COVID-19. And these include looking at the natural history, the transmission, and the diagnostics. We've learned a lot. Our first meeting was on the 11th and 12th of February. We didn't know an awful lot then. We've gained some, but not an enormous amount of information since, and I'm happy to take questions about specific issues if I can help you. I'm not on all of these 9 themed groups. They meet regularly, maybe once a week or once every fortnight, just trying to keep up with the research and gaining new knowledge. The next theme is looking at animals and environmental research on the virus origin and management measures at the human-animal interface. So looking at the zoonosis and how to keep humans free from COVID. Then the next one is an epidemiological study group, of which I was on that one, and I'm also on the infection prevention and control. That includes looking after healthcare worker protection. There's one, of course, everybody wants to be on this one, clinical characteristics and management of COVID. And that is an evolving feast of knowledge. And as we get new knowledge, we find we don't know an awful lot. Then there's therapeutics and vaccines, and that's where most of I think we're up to about 30 million now of donations have gone to, because you can have all the epidemiology in the world, but if you can't protect people, it's not really that important is it to understand the epidemiology. So vaccinations and therapeutics, including prophylaxis, are being looked at. There's ethics, so we're constantly reminded that anything that we come up with has to be ethical, including vaccinations, of which I'll be interested in hearing some of your thoughts about, who should get the vaccine. And of course, social science, which I think in Australia has been missing, the importance of social science. So as an epidemiologist with experience in SARS 2003, and I mentored someone through 3 missions of Ebola, you can't underestimate the importance of behavior. So you can't just look at the epidemiology without understanding humans, and also you need to get them on board and stop them from being pandemic fatigued, and also how to make them robust, and that includes doctors as well. How to make people robust, and psychologists and the range of health professions for the new knowledge that comes around, and particularly the public. So we get into a rhetoric and we get welded to it. Then the public get confused if we change that rhetoric. So social science is really important. May I have the next slide, please? This is just an overview of what's happening in the clinical management that I thought you might be interested in. So this particular group is looking at developing a standardized clinical case report form that's given to many countries around the world, so that we can collect the same data across the world. There's a web address there if you're interested in. Of course, looking at pregnancy during COVID as well, and they're looking at, of course, outcomes of pregnancy and outcomes of neonates. They're also looking at child cohort studies. We still believe that children are at less risk, but they usually do acquire it in family clusters. They're usually the last to acquire it. They were initially thought to be silent drivers, but they're certainly not like flu. We still have a lot to learn about how important they are as potential sources. Are they important at school? So what is happening in Victoria in the large, I think it's nearly 200 to date, of school children acquiring COVID. Did they actually acquire it at school? Are they at risk of spreading this to their teachers and staff? How much personal space do they need to spread this? What's their how easy is it for them to spread it to other children, or are they really spreading it between? Is it really family? Then they're pooling data to look at multiple clinical trials, and they are constantly updated. You've heard of the trial of the convalescent plasma. That's been going for quite some time, and anticoagulants, etc. Then there's, of course, the group looking at oxygen and respiratory support, and understanding whether or not patients who are mechanically ventilated, what are their long-term ill healths, how much steroids they need, and that's also another really important issue, because post-SARS there wasn't a lot published on it, but patients got neuropathy, but a lot of steroids, they were often given more steroids than they're doing this time around. Next slide, please. So there are constant publications and updates on the projects, and you can go to the WHO website and look for those. And the one that's happening at the moment that's under peer review will be interesting. It's about the impact of COVID on pregnancy and outcomes, and of course the persistence of SARS-CoV-2 in saliva, semen, vaginal secretion, and rectal mucosa. While there has been talk about acquisition of COVID, fecal oral, there's been no evidence that that happens other than finding virus in feces. So that's something that everyone's looking forward to seeing because we learnt in Ebola that, of course, Ebola can stay in semen for over 30 days. And so this may be the same, and it will be very important when we find out how long neutralizing antibodies last for, how long SARS-CoV-2 lasts for in vaginal or semen, to then provide good advice about safe sex. Next slide, please. So this is the just a few research priorities that we're doing in infection prevention and control. We're looking at masks in special populations. At the moment, we haven't come up with a definitive decision about children and masks, the elderly, and those with developmental or other cognitive impairments, and what we should do with them. We are looking at face shields as a potential option for the public, and also, of course, around the world, masks are in sometimes short supply, so we're looking at the safety of face shields used without a medical mask. Then we're also looking at the role of airborne versus droplet. Now, you've probably heard a lot about this. There were 236 scientists signed a letter sent to WHO about their concern that WHO wasn't taking into consideration airborne, which are, droplet nuclei transmission. Now, this letter was signed. There was a respiratory physician, there was the occasional physician, but there were very few epidemiologists and infection control experts, and there were mainly engineers. And we do not discount aerosolization, but the pattern, the epidemiological pattern, does not support this as a common event. We know it does happen with aerosol generating medical procedures. We know that there are aerosols in morgues with high pressure hoses and in oral and dental surgery. All of that, absolutely. But the idea of aerosols being important in public transmission or in transmission in your general practice, we haven't seen strong evidence. There was one paper looking at spread in a restaurant. One end of the restaurant had the COVID patient, and the other end of the restaurant, people acquired it. And they purport that they acquired this through aerosolization via the air conditioning unit. However, we haven't had any evidence of the viral load on the droplet nuclei that is at a level that is infectious, that can enter the epithelial cells or alveoli in a sufficient amounts to cause infection. My own research looking at flu A and B and what size particles flu came in, because there was an assumption prior to pandemic influenza that it only was found on aerosolized particles, was wrong. We found it on an array of particles, as we did in other respiratory infections. So it's not surprising that you're going to find COVID in different sized particles, and they have found this in Hong Kong with SARS and SARS-CoV-2, but that doesn't equate to a major risk yet. And one restaurant study does not make evidence, and also doing an air sampling finding some COVID-2 virus in the air does not necessarily mean that it's at a level that can potentially cause infection. Mind you, we also do require hospitals to have between 40 and 80 litres per second air change per patient. So there are many other infection prevention strategies, HEPA filters, negative air pressure rooms, and P2 masks when you are going to be doing aerosolized generation medical procedures. So we're looking at the effectiveness of different PPE. Some countries were interested in whether or not they can be decontaminated because some of the supply was at such a critical level, not just in low-income countries, but in some high-income countries too, including America. So we're going to be looking at, can you really decontaminate P2 masks without deteriorating their filtration? And then our priority is also looking at how infectious asymptomatic cases are and pre-symptomatic. So you will hear that many commentators suggest that the proportion of asymptomatic cases is up to 45, 50%. We've done, I was on the team that did a meta-analysis, and we found that it was between 12% and 18%. So on average, about 15%. That is in line with some other meta-analyses, but often the meta-analysis that have been published early on failed to take out the studies that didn't follow up the patients for at least 7 days. So to say you're asymptomatic, that you don't have any problems with smell or taste or temperature, you need to follow them because they may take a bit longer. So when we excluded those, the proportion of what we believe are true asymptomatics fell. Then, of course, pre-symptomatic, how infectious are you? So there's an understanding that we say that you're infectious a couple of days before you develop symptoms, but we'd really like to find that that is definitely the case. And the last one, of course, is ventilation. The importance of ventilation, of that air flow change. We know that being inside, not outside, is an important amplifier for a transmission. If you don't have good air conditioning and you have a practice in an old a terrace house or something else, or a place where they've got air conditioning that may not be at the standard of today, then it's a really good idea after having patients with a respiratory infection to open the windows and give them a good air, particularly at the end of the day. Please go to the next slide. Okay, so these are some of the questions that my group that I've been involved with are still interested in. So what's the asymptomatic rate? Just because we found it at between 12 and 18%, is that true? Will we find it to be different when we include more cases, bigger sample? How important are they in driving the pandemic? Well, at the moment, we don't think they're overly important, but how important are they, we don't know. So what's the duration of immunity for those that are truly asymptomatic and symptomatic cases? So do they have long-term neutralizing antibodies? There's been one study out to show that, very sadly, it was unlike SARS in 2003, where you had a peak level of neutralizing antibodies at about month 6 after infection. Then it started to decay, and by about 18 months, 20% of patients had no immunity. Well, the paper that's come out recently suggests that neutralizing antibodies at the moment start disappearing at about 3 months, but that's just one study, so that doesn't make evidence yet. That just makes us worried. We're looking, we need to look at the impact of pregnancy and their outcomes, as I mentioned. Also, do children drive this pandemic? We don't believe so, but if Melbourne does an epidemiology study of their school children, that will really be potentially a game changer for us if they find something different. Can we really prevent family clusters? Well, I think that you'd agree that we can't. Sadly, we tend to lock down families with an infection, give them some infection control guidelines, but it's very hard if you don't have a dedicated bathroom to not catch it. And of course, by the time one of your family members has been found to be positive, well, they may have been infectious a couple of days beforehand, and at least the partners may be infectious, and the children may be able to not become a case. Of course, if they're teenagers, they have probably an even better chance of not becoming a case because they usually hide in their bedrooms most of the time doing their study, don't they? We're looking at the role and infectivity of aerosol versus droplet particles, as I mentioned. So we haven't stopped looking at that, and the role of ventilation, and of course, face shields versus medical grade masks. Next slide, please. So just briefly looking at how we're going around the rest of the world. So these are a number of cases by area. So WHO divides up the world by different regional office areas, and that one of the biggest ones is the Americas, and America per se, and Latin America is in there. Can you go to the next slide, please? And we're right down the bottom. So if we go to the next slide, this is where we were. We are in WIPRO, so the Western Pacific Regional Office. We have 288,892 cases in our region. Now that region does not include Indonesia, so I'll quickly show you Indonesia in a moment. And there are 8,237 deaths. Now that death rate of 2.85, that really isn't a perfect death rate. Death rates where you use the number of deaths divided by the number of cases is not really accurate because you haven't had a chance to recover or die. So you either count back an average incubation period and use that group, or 30 days, because it often takes patients 30 days to die, and use that cohort of case numbers to then do a proper death rate. So that death rate is will be adjusted later on. As you can see, China had 83, nearly 84,000 cases. But interestingly, if you have a look at the number of infections per million, they're at about 58 cases per million. That's very few. Taiwan is 19. So, and why is that? Because they were early adopters of masks and lockdown and ring fencing and testing. And Australia, of course, we were, the last time I looked, about 300 cases per million. So there we're up to, sadly, 14,403 cases. Would you mind going to the next slide, please? Okay, so this is in the Southeastern Asian region, and it will just give you the number for Indonesia because they're our closest neighbors, and they're at about 100,000 cases. Now, that may be an underestimation because they may have issues with surveillance and the ability to test, but it gives you an idea that it's very high. And of course, India is sadly over 1.4 million cases. And our neighbor Timor-Leste is at 24 cases. Could you go to the next slide, please? So I've only got a couple more slides, and I was asked to navel gaze at what would happen in 2 months and 2 years. So I think in 2 months we'll be same, only a little bit different. We have done really remarkably well with Western Australia, South Australia, Northern Territory, and Queensland and Canberra. We need to be mindful about the Northern Territory because I understand we may be having some troops over from America, so that could increase numbers, hopefully not. So what might happen in 2 years? So for the 2 month one, so in Victoria and New South Wales was doing very well with a handful of cases. Now, you'll hear people talking about the R number. One of the problems with the R is that it's usually a little bit behind what is happening, but it also assumes that everybody in New South Wales has the same latency period, the same infectivity period, all sorts of same. And there are 3 or 4 ways of doing R. And 2 of them don't really take account of population size, but they don't take account of the difference between a population, say in Melbourne, where you might have a large proportion of, and I think it's about 41% of cases are somewhere between 20 and 39 years of age. Now, they will have potentially 20 contacts a day, where somebody older may have fewer contacts because they're not taking kids to school or they're not highly socially engaged. So the R doesn't take account of very different populations and different risks, as we've seen with aged care. So another way of doing it is looking at what I do, apart from looking at daily numbers, I look at also how we go over a double incubation period. That's what we often do to feel comfortable that we're getting close to the end of an outbreak. Now, we don't expect the end of this outbreak, we just expect very small numbers. So over a rolling 2-week period, you would hope that the numbers would be less than 100. And I suggest 100 because each person, even if they only have 10 people, over 14 days, it means the contact tracers have to contact 1,000 people, and they can't contact us at 9:30 or 10 at night. So it makes their job difficult, and they have to make contact before day 3, because day 3, day 4, day 5, they may start to have become infectious. So you've got to get all contacts rapidly to move them away from susceptible populations. So I look at a rolling 14 days, hoping that the numbers stay small, and I look between several different 14-day periods, and I do a ratio. And New South Wales was doing brilliantly before, sadly, the importation of case from Victoria. And we were so close to eradication, I would have said, congratulations, it's eradicated nearly, as you can do during pandemics. You never get 0, really. There usually is maybe 18% of asymptomatics out there still causing other minor infections, and people taking time to actually go and get tested before they get put in isolation. So you will still have numbers going, and if we can get the numbers down in New South Wales again, we'll do very well. Victoria has a challenge because they have it from many different areas. They have a creeping number coming up in the healthcare workers. There are 400 of them currently infected, and some of those are from carers from aged care, and they were not required or didn't wear masks when healthcare workers were in hospitals, and so they often work across several different facilities to make up money. And this is where social science needs to come in to start making a difference in our interventions. It needs to take into account the inequities in the community and how we can think and plan prior to, what might happen. How can we prevent this from happening in the future? So hopefully in the next 2 years, we will have started to think proactively and plan and get more social scientists involved. May I have the next slide, please? Then in the next 2 years, we have at the moment 166 vaccine candidates. 25 of them are in clinical evaluations, and I know that a couple of them are already going into Brazil, in Rio de Janeiro, for example. They'll be trialing. Altogether, there's a group from Sinovac Tech from China and another one from the UK, and together they'll be doing 2 different vaccines, but altogether looking at the effects in 9,000 Brazilians. So hopefully they'll find some positive impact. And then there's 141 candidate vaccines in preclinical evaluation phases at the moment. The big question needs to be, because humans are clever, we've got to the moon, we've got to cameras and robots on Mars. We can do this, although we weren't successful with Ebola, MERS, or SARS, probably because the numbers didn't require the effort. And this particular effort is quite remarkable, how the scientists around the world have got together to try to solve this. But the next question is, who will get the vaccine? So from an ethical perspective, of course, frontline healthcare workers need the vaccine. Then who else would you vaccinate after that? Because the production and getting the vaccine out into the community is huge. It's a very big ask. A number of those candidate vaccines, of course, are being sponsored by other countries, and they will want to vaccinate their population first. WHO would like at least 500 million children vaccinated. Now, you will say to me, well, children have less risk of becoming a case, and that is true. But equally, and this is assuming that the vaccine has long-lasting effects, but I pose to you that the children and the young in their 20s and 30s should probably be the next group as well, because they're our future and we don't want them to have long-term ill health effects, because those of us in middle age and older, we can move over and let the 20s and 30s have a healthier future middle age as we mainly have. So it'll be a very interesting ethical conversation, and I'm hoping that the children, the teenagers, and the 20 and 30s are the first group that get vaccinated after the frontline group. Next slide, please. So how will your service be impacted? Well, listening to the clinical managers and the clinical epidemiologists at WHO, I've come up with a couple of ideas. So next slide, please. And there's a book written by these 2 authors called Predictable Surprises, The Disaster You Should Have Seen Coming and How to Prevent It. Well, and most events that catch us by surprise are both predictable and preventable, but we consistently miss the warning signs. Well, that is absolutely the case when it comes to running COVID, because we keep making the same mistakes. And hopefully we don't keep seeing more people get infected, because I fear that you will have patients that you will need to look after from exercise capacity reduction, sleep apnea, chronic lung function abnormalities, psychological and cognitive impairment, quality of life reduction. And we really need to lift our game in doing more preemptive approach to ensure that you don't have to change your practice because the future patient groups coming through have some of these nasty long-term effects. So I've suggested that you plan for rehabilitation services and you make it your services multidisciplinary, having physiotherapists, occupational therapists, psychologists, speech pathologists, dietitians, respiratory physicians, and I inadvertently didn't include psychiatrists there. So there'll be many problems, and when I went back to Hong Kong just after SARS, I went back in, I think it was July or August, I was tasked with a job to talk to the healthcare workers about what we learned during SARS, and we were going to rejig the health services. And so I thought I was going into a very large room and I was going to talk to all these health experts, and we'd be talking about what we'd learned and how to plan, and it was all going to be pretty easy. So as I started my spiel, I asked for a few of the healthcare workers that I happen to know, could they get up and tell us what did they learn and what can we start planning for the next time. And honestly, I had a room of, there were hundreds of healthcare workers there and they were crying. And so I'm not a psychologist or a social worker, and I realized that I was way out of my depth, that I hadn't expected such PTSD. Healthcare workers in Hong Kong are very tough and pragmatic, but they had seen their colleagues get SARS, have to be intubated and catheterized, and then they'd seen their whole country go through SARS. Now, SARS in Hong Kong had the second highest number outside of mainland China, and yet that was only I think it was about not quite 6,000 cases, and we are talking 14,000 cases, and we have to stop talking about mild cases. I think we need to reclassify them as non-admitted cases or non-medical intervention cases, because your patients will have potentially a long time to get over SARS to COVID-19, not just the 6 weeks that the authorities put up, that, you know, by 6 weeks everyone who is going to recover has recovered, and it's not necessarily the case, and that they will suffer from PTSD, as many of your own colleagues will. So I think don't underestimate the impact of the psychology, the psychological impact, and the fatigue, the pandemic fatigue that you may need to address. So that's all I have, Michael.
Thank you so much, Mary Louise. That's a really fascinating overview of what's been happening. As our next speaker gets ready, I just had one question before we, and we're, just for now, is given what you know, I mean, particularly with that research that you've been looking into the effectiveness of masks, if you were a health provider working in a community setting, would you be wearing a mask for all of your patients?
Well, so I can, a mask wearing all day is a big ask. And during SARS 2003, I was tasked with finding out how healthcare workers got SARS. And we came up with the conclusion that you shouldn't have to wear a mask for more than 4 hours because it's exhausting. It's hard work. And of course, the WHO group are looking at skin complaints, all sorts of things. But I'm hoping that our analysis of the effect of shields, face shields, will be able to give you an alternative to wearing a mask.
Okay, thank you. That's really helpful. And we'll have more questions in the panel discussion. We're just running a bit late, so I might let the other couple of speakers do their presentations. Our third speaker is Martina Gleeson. Martina's a GP in Caringbah, has been working in the Sutherland site for 30 years, supervisor for GP training, and one of our great advocates and leaders within the Health Pathways program. And Martina, I'll hand over to you to talk about a COVID safe practice.
Thanks, Michael. There we are. So we are all required by the RACGP Accreditation Standards Edition 5 to have a safety plan, and all of us should have had a safety plan prior to the pandemic starting. But I probably would hazard a guess that a lot of us have been chasing our tails to get up to speed and get our safety plans more realistic. It's based on the RACGP Pandemic Flu Kit Implementation Guide, and that QR code that you can see on the screen actually takes you to the Pandemic Flu Kit, which has got a lot of helpful information for preparing for a pandemic, but it is specific to influenza. But it involves the prevent and prepare stage, which is where you're planning your infection control studies and identifying and managing risks. And then your response stage, which is as the pandemic is emerging. That's what we were starting to do in February and March of this year. But it involves also reviewing and implementing your pandemic plan based on the stage of the pandemic and continuing to adapt as the pandemic develops. And haven't we been doing that? And then the final stage is recover and maintain, getting our regular services back on track. So depending on that vaccination, I think we're a little while off for that. Whereas in my living memory, the last pandemic I lived through that affected my clinical care was the H1N1 influenza pandemic, and I think that was over in about 6 months. What's different about COVID? Well, it's got something to do with the virus characteristics. We have pre-symptomatic and asymptomatic spread. We have a much longer incubation period compared to influenza, and there's the question of aerosol spread. There's also the disease characteristics. This is not just a respiratory virus, it's a multi-system virus that affects many systems, and there appears to be a post-viral syndrome that's quite severe for a number of sufferers. And there's also the question of vaccination and therapeutics. There isn't currently a successful coronavirus vaccine model, as opposed to influenza, where we had successful influenza vaccine models to rapidly adapt for the H1N1 influenza. And we don't have any current antivirals or therapeutics that we can apply across the board to reduce the amount of time that people are sick and the severity of the illness. So that's all impacting on how we manage and try to make our practices safe for COVID. I'd like to encourage you to have a look at your local health pathways because we've got some great COVID management pathways that are really kept up to date and very relevant to what I'm talking about tonight. That QR code will take you to the Southeastern Sydney Health Pathways, which is the health pathways that I'm a member of the team of. And if you want to take a photo of that screen, if you haven't already got a username and a password, that gives you one. If you're not from our local health district and you want to get access to your local health pathways, I'd suggest that you have a look at your own PHN and ask them for the log-on for your health pathways. Every area in New South Wales has access to the COVID pathways. This is the Sydney Health Pathways. They're our other team in our PHN. That QR code takes you to their program. They've been going a lot longer than us and have a lot more pathways, but we share pretty much the same COVID pathways. So I'm trying not to go too slow because we're trying to catch up, but one of the most important things you can do when you're coordinating your response is to appoint a pandemic leader and coordinator. There are role descriptions that you can use for these roles in the RACGP Pandemic Influenza Response Kit in section 2. But the important thing also is to ensure communication with the rest of the team regarding changes in guidelines. Changes are happening all of the time. So you need to work out what your methods are going to be for that. Our practice has adapted a practice-wide WhatsApp group And so any changes that any of us become aware of, we can post to the WhatsApp group and have a discussion about how we're going to adapt. So, for example, that mask recommendation that New South Wales Health released with the Amber Alert on Thursday was posted straight away on our WhatsApp group. We didn't need to make an adaptation for that because we had already started wearing masks and asking our patients to wear masks, but we did feel validated in the decision we'd made earlier in the week. You might decide instead to have regular team meetings, but you need to bear in mind how you're going to do that and maintain your healthy distancing. Or you might have a practice manager or the pandemic coordinator producing a newsletter and sending that to update into everybody's inboxes, however often is needed. But as a practice, you just need to make that kind of decision. You need to come up with some safe work practices for staff, and I've enclosed some photographs of the setup in our practice. So that top right-hand photo is my consulting room with some hazard tape that measures 1.5 metres from where I sit. And the waiting room, that was early in the stages where we removed every alternative chair. We've actually removed even more chairs now and only have 4 chairs in each of the waiting room, which means that we need to manage patient flow into the practice so that they're not sitting and waiting for too long because we don't want it to get crowded. We need to be doing things like limiting the number of chairs so that we can have physical distancing in the workplace, obviously enhanced cleaning and disinfection protocols, and training of all staff members on the correct use of PPE. We need to be participating and developing education and training of all of our staff, not just medical staff, making sure they understand what COVID-19 is, implementing our infection control measures and what their role is in that. There's also been a lot of education we've had to participate in and pass on in the effective use of telehealth, and making sure everybody in the staff, even the cleaners who come in maybe from outside, that they're up to date on our key policies. Obviously, triage is an important thing and something that's going to be important ongoing until the pandemic is over or we have effective immunisation. It needs to be rapid and safe. Most of us, I think, are utilising telephone triage or even triage in the computer login stage, so that people have to ask questions before they make their appointment. A lot of practices are doing an initial telehealth appointment for all patients with signs of respiratory infection. Some people are also doing an initial telehealth for all patients, full stop, and only inviting the patients in who need to be seen for a physical examination or a face-to-face after their history is suggestive that they're safe to come in. But with asymptomatic and pre-symptomatic spread, every patient that comes in is putting the other people in the practice at the time at risk. So we do need to be careful. You might also have somebody at your front door who is confirming patients who have no respiratory symptoms as they enter the practice. We certainly have someone doing that for us, and you need to develop some processes to manage those clients with respiratory infection. I'd just like to take a minute to show you the Health Pathways COVID-19 practice management pathway. And first, I'd like to point out that it was updated yesterday. So you can rely on these pathways to be updated with new information as it becomes available. So if you're thinking, what is the one place I can look at that is going to give me up-to-date information? The PHN website coronavirus page has been very helpful, but you might also consider looking at the Health Pathways COVID pathways, because you really can rely on them being up to date. So you can see it's gone through for practice management, appointing, the coordination, and then it talks about infection control. I mean, you can see these drop-down boxes, as you open them up, give you a lot more information. So the reason why we have them as drop-down boxes is you might be quite happy with your practice setup and your staff behaviours, but you might want a tip on patient education. And so you don't want to have to scroll down a whole lot of the pathway just to open up, say, the patient education, which is going to give you links to a whole lot of helpful posters and videos that you can perhaps link to your practice website or be playing in the waiting room, or just making available to patients. But in the practice setup, it goes through PPE and disinfectant, considering closing off some areas of the practice from patients with fever to allow segregation and social distancing and isolation. Transparent screens at reception to protect staff from aerosol spread. A lot of really practical suggestions on how to manage the infection risk of COVID-19 in your practice. It also goes down and has a look at how we can deliver effective care to our patients. Some of the things I suggested, like controlling access to the practice, preparing and thinking about how you're going to look after your vulnerable patients. I'm sure a lot of us put a lot of effort into considering how we ran our flu clinics this year, how we managed to immunise large number of patients as quickly as possible while still maintaining healthy distancing and reducing the infection control risk. It was a huge undertaking by most general practices, and I have to say I'm very grateful to many of my colleagues for sharing how they addressed it so that we could come up with an effective plan for ourselves. Talks about managing and protecting your staff, and I'm not going to go through all the details because I want to really just let you know that this resource is available for you to have a look and take you through it a little bit just so that you can see how extensive it is and what a valuable resource it can be for you. I also want to point out that there's a telehealth pathway that helps you with what you need to be doing and making your telehealth consultations more effective with patients. It's been such a time, hasn't it, with so much rapid learning, so much development of extra skills. In some ways quite exciting, although I'd rather not have it in these circumstances. But there are also some extra populations that this deals with, so special arrangements for Aboriginal and Torres Strait Islander patients, how to arrange a link to interpreter services that you might use with a telehealth, and some basic information on how to manage the telehealth consultation. The other pathway I'd like to point out to you is the COVID-19 recent changes pathway. And what this does is it lists all of the changes in all of the COVID pathways that we have available. So if you have a look at the practice management one, you can see that it was actually, as I pointed out, updated yesterday. And it tells you what those updates were, the PPE guidelines and information to include the New South Wales Health Amber Alert, which was released on Thursday. There's also been changes to the initial assessment and management page just on the 27th of July. So if you're thinking at the beginning of the day, what do I look at? You can have a look at the recent changes, and if you scroll down and go, there haven't been any changes since I read this last time, then you don't need to click into all of the different pathways, presuming that you've already read them, because you know that you're up to date. So that is something reliable. We obviously want to be trying to still provide best practice clinical care, and some of that is challenging, but something that's evolving. We initially put off bringing patients into the practice, and now we've got to work out how to bring them in and under what circumstances they need to come in, so that we can catch up with them and keep an eye on chronic illnesses in particular. So these are some suggestions for best practice clinical care. Where to from here? Because we really are talking long term now. So hopefully we'll continue to have telehealth funded through the government, through Medicare rebates from the government for, you know, well into next year, because the pandemic's not going away anytime soon. I understand the issues with mandated bulk billing, and that is challenging, but we just need to be thinking about how we can incorporate telehealth where appropriate, maybe with sometimes combining, doing some telehealth and some face-to-face for the one episode of care, so that we limit the amount of time the patient's actually in the room. I'm hoping that there will be continued funding of respiratory clinics well into next year. I'm a bit concerned that there isn't a respiratory clinic in the Sutherland or the St George area. It's a long way from Cronulla to Maroubra or Double Bay, which are the closest respiratory clinics from where my patients live. And there's also emerging electronic health technology. We're learning a little bit better how to use secure messaging, and we in the Health Pathways team are working pretty hard to try and get better better access through secure messaging to our local health district outpatients. Sydney Local Health District have been running a fantastic program to help GPs working in the Sydney Local Health District use the HealthLink to refer patients in, which is great because it saves that necessary of picking up a paper and handing it to the patient, and it also saves the staff from having to fax referrals and wonder if they ever turned up. There are options for pathology and radiology ordering, and communication with patients is another thing where secure messaging can be helpful. We need to work out how to continue doing our chronic disease management and our health assessments, bearing in mind that there isn't a telehealth item number for health assessments, but I think they're becoming even more important, especially if people have had a serious illness, and we need to reassess where they're at and plan their recovery with them and what their needs are. There are mental health consequences of this pandemic. We're all getting a bit tired. It sort of took a while for us to realise that this was a marathon, not a sprint. So we need to be aware of the mental health of our staff and patients. Some of the things that we've done in the past as organisations to help look after the mental health of our staff, like having lunch together or going out together for dinner to maintain the social connection, is not as easy to do. So we have to be a little bit creative about trying to work out how to stay in touch and keep aware of the human side of the people we're working with. And obviously there's ongoing occupational health issues. We've got doctors at risk by elderly or with medical conditions. We need to be able to provide for them to practice in a safe way, maybe working from home, but that involves its own challenges in terms of VPNs and remote ordering of, remote managing of the electronic system. So some of these things are emerging already, but I think the realization is that this is going to be quite a long go, and we need to learn from, build on what we've already developed and continue to learn. I've sort of run through that quite quickly, Michael, to try and get us back on time. So that's the end of my presentation.
Thank you so much, Martina. And thanks for the sort of practical tips for GPs. Just when we get the, sorry, I'm not quite sure what's happened there, bit of feedback. Can you hear me? Okay.
Yes.
Yep, okay. No, I'm going to ask you a bit to clarify a little bit more about that Amber Alert, but I'm just going to pass on to our final speaker first, who's Dr. Michael Bonning. Michael's the Medical Director of Inner West GP Respiratory Clinic, GP at Balmain Village Health, and Chair of the New South Wales AMA Council, and Deputy Chair of GP Synergy. And Michael's going to talk about working in a COVID-safe environment and treatment of acute respiratory infections.
Thanks very much, Michael. I recognise that some of this is a bit, it doubles up on what Martina was just covering, which is good. I mean, we're all coming from the same place. We use the health pathways. And I think some of what I'll say here is needs to really remain my own views about how to do some of this, and that really this last couple of weeks has underscored that issue of pandemic fatigue amongst us as colleagues. And you know, I think many of us were on that pathway to recover and maintain. You know, even a short period where we weren't necessarily back to business as usual, but we were certainly back to having a much more normal looking approach to practice. And now with masks and, you know, more respiratory risk in our community, we've needed to, you know, to step back from things. I also, and I know this is a community within our own footprint of CESPN, so you know, we do need some more respiratory clinics. We need one down in, or at least one down in Sutherland Shire, or out at St George to support the service. I know the leadership at CESPN have really been trying to achieve that. It's also, I think, inconceivable that the respiratory clinics will not continue past the end of September, simply because they you know, are seen as one of the clearest ways in which the Commonwealth is contributing to this, you know, from a testing point of view, and therefore you know, they're a marker to the community of what we're trying to achieve. Bertha, I'll go on to the next slide if that's okay. Look, everything that was simple in practice is just really complex these days, and this is really a distillation of a lot of what was being said. That, you know, even the guidelines on mask wearing from the RACGP and New South Wales Health and COVID safe behaviours are in a, you know, pretty constant state of flux. You know, and for many of you who are close to central Sydney, you know, there's some, you know, some cases that are very close by to maybe where you live or where you work, and that's, you know, that brings with it its own sense of, for people in your practice, you know, a sense that risk that has always been there is now much more palpable to them. And, you know, more than anything else, it's about you know, trying to find a shared approach to risk management. And that's not just of COVID and respiratory illness, because like Martina was talking about, we've still got a lot of chronic disease, and as the professor was talking about earlier, when we look back at the experiences of other countries from previous pandemics, the hangover effects of undiagnosed conditions, you know, cancers, cardiac conditions, other respiratory conditions, neurological problems, do follow us for many years afterwards, which create their own, not just COVID-related problems, but also their, you know, what's going on there. So that's, you know, that's why we're, you know, we as GPs have to, you know, do what we can to continue that, many of those processes that we would normally undertake on behalf, you know, with our patients. So Bertha, next slide. Well, as we're going there, as we're going on to the next slide, the complexity of all that is around knowing your individual risk tolerance. I see that my last dot point got cut off there, but it's about each individual. We know that there are vulnerable practitioners within, and other people within our practices, but really it's also, someone can not have what we would consider to be vulnerable, but they're concerned, and they have other concerns or things that fall outside the scope of their own individual vulnerability. And I think that's important to recognise, that different risk tolerances, and how you go about trying to communicate that and coming back to it. And sometimes this isn't based on science, it's rather on individual concerns or what's going on more broadly in the community or in the media, and just keeping that in mind, because it's easy to say at the moment, oh well, this is the science, but lots of times we're not even quite sure on the science of what we're dealing with, as was, and we seem to have gone forward a second slide there, but it is around that, you know, trying to share that communication. Now, in circumstances now where, you know, you try and have team meetings, whether that's via, you know, discussion groups or WhatsApp, but it's really important as well to let people be heard. And so to actually, sometimes that means needing a proper practice meeting, so that we can ensure that people actually get to have their say, and remembering to include everyone in that. So, our allied health staff, our reception staff, our nursing staff, our practice managers, alongside our GPs. And again, Martina was talking about it, but that idea of how and who and can we reproducibly screen for respiratory symptoms? And sometimes that means for all the things we put in place, we can't or we don't. And while I wouldn't necessarily advocate for going back to any form of solely telehealth, though some practices may well want to go to that at some point as risk changes. It is a very powerful tool for screening and for risk assessment, because you actually get to see or listen to a patient. And we've still got many patients in our community dismissing their respiratory symptoms, and they get through first pass screening. So they get through the website, or they get through the receptionist, or and they somehow land in our room. The most common example I've seen of this is the patient who, or they're not the patient, they come in with a child or an infant for vaccinations, and they they have respiratory symptoms, even though they've kind of downplayed those. As much as I'm big on supporting health pathways, I do use the New South Wales Health resources, just because I have this just saved as a link in my browser on all sites, because I need to see those most regular updates, and we know that page can change multiple times across the day as new cases are found. So just next slide. So you seeing this, and advice on testing for those of you who have the slightly tricky scenario which has come up recently of people needing to fly internationally who require a test. I want to pass on some information that came through from the Deputy Chief Medical Officer, which is that we can and should test for that indication. It was surprising to hear that, given that those people are asymptomatic, but obviously they fall into what we'd probably consider a special category, not because of their current risk, but because of their potential for risk to others if they get on an international flight. And it seems that either the country of destination or the carrier are the ones now demanding those tests for people to get on there. We expect those to remain a fairly small component of your or our or anyone else's work, but it's important to recognise that and note that that's not necessarily updated on the health guidance with New South Wales Health just yet. So carrying on to the next slide. And we try and work in our area, and I know I'm in the lucky position to run a respiratory clinic, so I can we've built the respiratory clinic we want as clinicians in our local area, which is lots of talking with local doctors, but also trying to stream our patients in certain directions, which is that, for those who are well with mild symptoms, especially teenagers, people in their 20s, those in their 30s with no other risk factor, individuals at home, then often easiest place and quickest and most useful place for allocation of resources is through the pathology drive-through clinics or the LHD clinics. But we know that access to results by their regular GP is actually quite variable. The pathology drive-through clinics seem to do things better there than the LHD COVID clinics, and that's been a consistent source of difficulty, I think, for us as GPs. For those moderately unwell individuals, whether you're comfortable in your practice on testing and examination, especially maybe later in the day, segmenting out your day. And Michael Wright's been asking many of the panelists, and amongst them, I will say that I try and segment up my day in regular general practice to see vulnerable patients in the morning, to do a raft of telehealth in between, and then because then I put my mask back on again after the vulnerable patients in the morning to see those who may have more risk factors associated with them for COVID or for other respiratory illness later in the afternoon. And the other place we can see those people who are moderately unwell, so have a respiratory illness, is through the GP respiratory clinic system. Now, again, every respiratory clinic is different, but the one that, and a lot of the ones that are being run within our footprint, really try and focus on a true respiratory assessment, and trying to, again, hopefully provide regular communication back to the GP. The regular GP sits at the centre, and we're all just bolt-ons in terms of service provision. So, hopefully in that way as well, if you've telehealth someone and you want them to come to a respiratory service, then providing that information through, because you've often got, for those more complicated patients, you've got substantially better history than can be gathered in even 20 or 30 minutes of FaceTime or talking with a patient, because they've, complex medical histories. And we often think the distinction between, well, what's the difference between the GP respiratory clinics and say going to the emergency department, is we're so focused on respiratory management in the respiratory clinics that patients with other symptoms, or whose other symptoms make a non-respiratory cause likely for their symptoms, so a cardiac complaint, or other reasons, so a significant ENT issue, or they're at significant risk of deterioration, they do need to go to emergency, because we're so focused on respiratory management. It means that we're actually not. It's not that we can't do it like other. We can do it, but it's that we don't often have the equipment or the availability of that. We're not in a position to run, do an ECG and troponins, because we just don't have that access. We need someone to essentially have a period of observation in hospital, and that's sometimes the distinction, and especially that goes for children. Children, I think, are a tricky space, because many with a respiratory illness may need, more than anything else, a trial of fluids, or maybe a trial of, for some of them, a trial of Ventolin, and that we may, to stretch them out, they may need to be on site for a few hours, which makes the GP respiratory clinics not particularly useful for them, given that they're more a throughput model, on the kind of 20-minute, half-hour basis for appointments. Next slide, please. And I think this is the area where we get into the most difficulty. I think everyone's, we see amongst our within the GP community, is very good at the kind of front end. How are we doing this? How are we organising to assess patients? I think that's come along a long way from March and April, when we were all looking at one another and unsure. But now that there's a lot of testing sites, and there's a lot of there can be a lot of difficulty finding results. There's a lot of fragmentation of and a lot of time spent by GPs, I think, following that up. And I suppose the statement there is that everyone's having that same experience. It's not just you, if you are trying to do that in your day-to-day work. And I'll make this statement here, that there are some non-GP specialists that are asking for GPs to follow up results or undertake reviews. And we might always try and remind our non-GP colleagues that sometimes they're in the best place to do those things, and sometimes we need to have a bit more of a negotiated arrangement, because it can be difficult to get some of their patients straight back into our facilities, 4 or 5 days after they've been a hospital inpatient, or after being seen in other specialist rooms, and then coming back to us. And little things like changing the results follow-up process in your practice to defaulting that to telehealth, so that any reminders or things that are sent out to patients, it's now a face-to-face appointment, only when it's really needed, or only when there's something very material to discuss, and the patient jumps through the rest of the hoops. But we really want to think of COVID as being one of the challenges in providing ongoing patient care, where the GP remains at the centre of care. And so we really see this challenge, and a challenging patient that we're discussing there, when they test COVID negative but they have ongoing symptoms. And I think that's, again, comes back to everyone's individual risk tolerance. Is a COVID test always going to be 100% sensitive? No. Does it need to be combined with an understanding of the rest of their risks and epidemiological presentation? Yes. And sometimes that still means you will see that patient for a face-to-face follow-up, but using telehealth for lots of them, especially if they've gone and seen a emergency department or a GP respiratory clinic, someone has seen them, someone has had the opportunity to lay hands on them or put a stethoscope on them, so as to de-risk the process a little bit, and so the next follow-up can be like that. And also, if you have a patient that you're concerned about and you're concerned about that process, ask the GP respiratory clinic or someone else to manage both the initial consultation and the follow-up for a period of time, and just report back, because I think that can be really helpful, that there is someone who can readily see them and knows that they need there's a bit of shared responsibility there for what happens next. So, and I think I've got one last slide there. The step beyond coordination in your practice, I think, is local coordination with other GP practices. Where there are practices nearby, I think having that opportunity just to share knowledge, because while you may have a local COVID leader for pandemic response in your practice, as we're doing with the RACGP's guidelines, it's a bit lonely to feel like you have to have answers. And sharing information and having buddy practices, so you can at least see what others are doing and implement, and see what you want to do and how that fits with your practice, I think makes a lot of sense. It certainly helped me and us in our regular kind of general practice context. We've learnt from really good general practices in our area who made moves really quickly, and I think I call out some of them in our local area, because I think they've done that really well, and we've happily been able to learn from them. And that goes just the resources as well, having maybe some principles on a shared WhatsApp group. We haven't achieved that yet in our local area, but we're trying to, so that we know a little bit more about what's going on, because again, our little circle of maybe only a few GPs may not have all the information, but if we can share between us, and then we can also help cover things, because we know if GPs who work in smaller practices get ERTI symptoms, they can't work, and probably at the moment the ability to get cover is difficult. So it then becomes, well, can we all buddy up and support, try and support one another through this, because we've got to, I suppose, be kind with our colleagues, that it's a really difficult time. And if you happen to be near where I work at the respiratory clinic, I'll always take a call from anyone about anything. To the nice GP somewhere who asked me if I could do a pleural tap. It's been a while, but we're not quite at that level. We want the emergency departments to handle that. But anything about respiratory illness, anything about COVID stuff, often we'll be referring to health pathways like you will be, but sometimes it's the interpretation of where you're up to and what's going on. We're always happy to take and try and build that network, so we're all playing together as well as we possibly can. So yeah, thanks, Michael.
Thank you so much, Michael. And that tip around breaking up your day and resting yourself from needing a mask at different points, I think is something which I'm going to take back to my practice tomorrow and try to get over the mask fatigue. Now, as you can see, I've run way over time, and my apologies for the time management there. So we're not going to have time to do the full panel discussion, but what I was going to do is, our speakers have just agreed to all stay to sort of have one more question. Is Michael Bonning, are you still there? I suppose one of the questions that someone's just asked is, if someone has a negative result, but they've still got respiratory symptoms, do they need to isolate for 14 days? It's sort of this one that keeps coming up every now and again.
So I treat anyone with respiratory symptoms in in, once they've got a negative test, that's reassuring, especially if they don't come from a high-risk location. So there's obviously the New South Wales health list of people who need to self-isolate for 14 days. We really encourage people to self-isolate until the point in time when their symptoms have resolved, and that they're clear for at least 24 hours. Now, that's very difficult for some people with complex family arrangements or working arrangements that are, that are on contract or casual. That can be challenging, but if we can really try and reduce the amount of respiratory illness in the community, and that same goes for kids as well in daycare, and I know that's tough for parents, that will help us inordinately in this current scenario where we do have we do have spreading numbers of clusters, to help us differentiate illness, and hopefully help us meet, because if we're meeting a surge of cases at any point, our ability to test and assess is made much easier if there are fewer cases of other respiratory illness in the community.
Great, thank you for that. Mary Louise, I think you're on the line there. We've had a couple of questions with people asking about antibody testing, and I just wanted to know, do you have any thoughts on the utility of that, and if you think that will be something that would come to general practice, or it'll just be something that stays in the hospital setting?
Look, they're not overly reliable at the moment. There are many different versions that you can use. I think that there'll be something that you'll be mainly utilised through the hospital, but I think what GPs should be looking towards is a rapid point of care test. It may not have great sensitivity, but it might be something interesting for you to have as a method of identifying with all the signs and symptoms, and as your previous speaker has mentioned, where they have come from. If they come from a risk area, it might be something that where sensitivity and specificity improves all the time. So I'd watch that space. But as for the antibody tests, I think they're so overrun with the virology at the moment. It may well come into play a little later, but right now I think it won't be possible.
And can I just, given what you were saying about your research looking at masks and shields, do you have any early sense of whether shields might be at this point, would you recommend people use both?
I don't believe you need to use both. You're not doing, one reason that somebody would use both is if you ran out of P2 or N95 masks and you were using a face shield to provide additional support. But I don't believe you need to use both. And I think that there shouldn't be any reason why we won't find that face shields are efficacious, given that we believe the majority of the spread is droplet. And if you're having a routine consultation with the patient, I can't see how a face shield won't turn out to be as efficacious. But I'll let you know what happens when we get the results.
Great, we'll be very interested to see that. And then Martina, I know we touched on it. You were talking about the amber warning, and there's been a few questions about that, saying, does that mean that GPs should be wearing masks? Does that mean that patients should be wearing masks? And we'll send everyone to Health Pathways, but can you, I suppose, to go back in the morning, what would be your response to that question?
Well, our practice started wearing masks for all face-to-face consults last Monday before the Amber Alert was released on Thursday, and started asking our patients to wear a mask. We don't insist on the mask from the patient, but we did ask them to wear them. And as the week's gone on, more and more patients are presenting having acquired a mask in some way and wearing it. with various degrees of success, I have to say. A lot of them are coming with their masks on inside out and upside down, but we're trying to educate them so that they can wear them properly. The Amber Alert is, it has its jurisdiction for New South Wales health facilities. So, and GPs are not under the New South Wales jurisdiction, New South Wales health jurisdiction, obviously being general practice, we're privately and federally funded. But I really see no reason why we shouldn't follow that recommendation. I think if it's good enough for our hospital colleagues, it's good enough for us. And I think it's quite a reasonable and affordable step to take.
And I think even with what Michael was saying about this idea of breaking up your day, you know, having, you know, potentially seeing vulnerable people, then doing the telehealth in the middle, then you can do some stuff without the mask, and then dealing with more patients might be a way. So sort of managing your workload that way.
I do think wearing a surgical mask is easier than wearing a N95 or a P2 mask. They're very tiring to wear, whereas many of us have done long hours of surgical assisting or operating earlier in our professional careers and have, you know, worn masks for hours and hours and we've got used to them. So it is more tiring communication with your mouth covered up though.
Look, thank you so much. I think we might leave it there. Thank you for everyone for staying later. And I think we've got a lot more questions and a lot more things to talk about. So the PHN will run another one of these updates very soon. I'd just like to thank all our speakers for their time tonight in presenting, and thank you for everyone to attending.